some potential pediatric dentists of the future. They're here with us. They're some of our third-year students that they do a selective, Robin, with me on infant oral care. They do 3 months learning about how to deal with babies and infants in their practice. And they're so excited. They learn a lot, and they learn the value of early prevention. Early H1 visit is essential for the well-being of the children. And they're learning with this new philosophy of minimally invasive pediatric dentistry. So they're very excited about that. And with that, well, let me do a little bit of introductions while we're waiting. This is Dr. Robin Wright. We're so pleased and happy. And you met Dr. Scott Litch. He's our honorary doctor from the Academy of Pediatric Dentistry. Even though he's a lawyer with a dual degree in DDS by honorarium, since he's been there so many years, and he's an expert on oral health access. He gave a great presentation last week. But today, the light is shining on Dr. Robin Wright. By the way, I'm a fan of Dr. Wright since I met her many months ago, since the ADA. I mean, to meet Dr. Wright is to love her, because she's a wonderful, amazing individual, but not just by her heart, which is huge, but also her mind, her brain. She's so smart and so intelligent, and she brings the value of good communication, especially in oral health. Dr. Wright is the director of the Research and Policy Center for the American Academy of Pediatric Dentistry. She holds a doctorate degree in communication research from Northwestern University. Dr. Wright has taught at 5 universities and 2 dental schools, and is the author of over 100 publications, including the book, Tough Questions, Great Answers, Responding to Patients' Concern About Today's Dentistry. Joining the AAPD staff in 2015, she oversees research studies, analysis issues affecting children's health, creates policy-related publications, and supports advocacy efforts of both national and state levels. And I can tell you, when you hear Dr. Wright, you're gonna learn about the amazing skills and how really the tools you required to be a good communicator. I wish they would have taught us in dental school good communication skills, and this is our attempt to teach you guys or give you some thoughts and ideas through the advocacy work that we're doing with the Academy to really learn about the value of good communication. So with that, Dr. Wright, it's an honor to have you with us at UCLA. Welcome. I wish we have you in person, but hopefully next time you both will be here in sight. And the forum is yours. And thanks again for being here with us.
Thank you. That was like the nicest introduction I've ever received, and welcome to all of you. And thank you so much for giving up an hour of your time to spend with me. I am going to share my screen and just a little background on what we're going to be talking about today. You go to a party, you're looking to relax and just kind of have some fun. And what should happen, but someone finds out, sorry, I'm having a little trouble with my mouse. Someone finds out who you are and what you do. And the next thing you know, you are peppered with questions about children and their oral health. And it might go beyond that, because after all, you work with children. So you know what I'm talking about. And becoming an advocate for pediatric dentistry means it's a big step up, a bigger stage, bigger issues, more complicated issues, larger audience, influencing a lot more children, facing stronger opposition. And there's 2 reasons why we're talking about children this evening. And that is that, you know, when you are already sharing with one-on-one or in your communities and throughout your university, you are already speaking for children. And I can assure you that you're probably very good at it already. And your personal experiences and your insights are the heart of your messages about children. What I'd like to do for the next hour is to give you a framework, something that will underline, kind of hold up a lot of your personal experiences about children by looking at them in terms of economics, in terms of healthcare, in terms of oral healthcare, dental visits. So you have a sense of what's going on across the country that will help support the personalized messages that you are able to give when you are advocating for children. And I just like to mention 2 reasons why I am so happy to be working for you at the AAPD. And the first is that you do not go to your communities or your state legislature or your nation's capital to advocate for yourselves. You truly go to advocate for children, and that sets you apart. The other reason I'm particularly proud is because unlike some other health associations, and of course I would never mention their names, AMA, they do not represent even half of their profession based on membership numbers. And the American Academy of Pediatric Dentistry represents 93% of the pediatric dentists in the nation. So that's 2 reasons why I think you will find that your forays as an advocate in pediatric dentistry will be on a very solid footing. Okay, so we're going to be looking at a snapshot of America's children. Here are the topics that we're going to be talking about: demographics, family health, oral health, dental visits, and then a quick look at parent perspectives. But before I get into these specifics, I'd like to take a quick look at your market share, if you will. The first is taking a look at what percentage of children do you treat. And you can see there that on average, you treat a little over a quarter, but it varies according to age. Now, keep those numbers in mind and take a look at the number of pediatric dentists that there are in the nation. And there's around close to 8,000 pediatric dentists in the nation compared to a far greater number of general dentists. So you do in fact treat a large, you don't have the largest market share, but you treat a sizable market share in terms of your numbers. Okay, so let's start with some child demographics. And okay, quiz question 1. Do you expect the US population to become older or younger by 2050? What do you think? Are we getting older or younger as a nation?
I think we're getting older as a nation, no?
Yeah, I'd like to hear from everyone. Okay, I heard someone say we're getting older as a nation. What do you think? Do you agree?
That was Tarek. Who else? Do you guys agree? Just can raise your thumb, or if you disagree, say it. Some raised hands are out there, Robin.
Okay. Unfortunately, it's hard for me to see all of you.
Yeah, no, I will guide you. I can tell you.
Okay, so older or younger, what's the consensus?
So there's some thumbs up for older and there's one for younger, so.
Okay, well, whoever guessed younger, sorry, but you're going to do so much better on the next quiz questions we have coming up. Yes, in fact, although whoever said younger, you do have a point in your favor. Yes, we are getting older as a nation, but on the other hand, the number of children in the US is projected to increase. So we're looking at about 73 to 78 million from 2020 to 2050. But even though the number of children is getting bigger, it is a smaller percentage of the population. All right, let's come up and take a look at What are the race and ethnicity percentages that are projected for your future over the next 30 years? You will see that we are expecting an increase in the Hispanic population, a decrease in the white population, Asian population, some increase, and an increase in the 2 or more races. So that is the face of the patient that you will be seeing over the next 30 years. Quick look at family and community. We can see that some aspects are getting better. I'm sorry for the size of some of the numbers that you may see on your screen, but basically in the last 10 years, what's been going on? We see that children in single parent families stayed about the same. Children in families where the household does not have a high school diploma, getting better. Children living in high poverty areas, getting better. Teen births per 1,000, also getting better. Next up, is quiz question 2. Francisco, I'm gonna be relying on you to let me know.
Yes.
Okay. Youth ages 12 to 17. So we're talking about your middle schoolers and your high schoolers who are involved in a serious crime, either as a victim or as an offender. Has it gone up? Has it gone down? Has it stayed about the same? Or take my wallet and cell phone, just please don't hurt me.
Maybe put it in the chat, or you can actually just put your thumbs up for increase. You want to put your thumbs up for increase? Anyone for increase? Anyone for B? Anyone for decrease on B?
What do you think?
I got a few thumbs up for decrease, Robin.
Excellent. Well, I guess then that you are not going to be as amazed as I was, because not only have they decreased, but they have decreased substantially. I mean, take a look at this. Victimization has dropped in half in about the last 10 years ago. Offenders have dropped almost in half in the last decade or so. And I thought, okay, I'd like to know why. And to be honest, the answers are kind of vague. It's like, well, we're not sure why. We're just really, really happy about it. A couple things is, one, crime is cyclical, and there was a big bump up in youth-related crime in the 90s and the early 2000s. And the other reason is because they think it's the active and more frequent intervention earlier in children's lives that keep them from going down a path that can lead to crime involvement. Next one up is, let's take a look at economic standing. Quiz question number 3. What percentage of U.S. children are classified as food insecure? 1 in 4, 1 in 6, 1 in 10, or none? Please pass the donuts.
So A, who's for A? 1 in 4, can you put your thumbs up? There's a couple of 1 in 4.
Okay.
How about B? 1 in 6. Anyone's for 1 in 6? There's
I'll say 1 in 6.
Yes, there's like more in B, Robin. And how about 1 in 10? Anyone thinks 1 in 10?
Not too many.
Not too many 1 in 10. I think B is the takers.
You are all super close. It's 1 in 6, but just a few years ago, it was 1 in 5. So if you picked 1 in 4, very, very close. And when I first ran into this language of food insecure, I thought, what exactly are they talking about here? Are children going hungry or not? And so I thought I would share with you some of the definitions that we of language that we now have that we can use in talking about food insecurity. And you can see low food insecurity. It's not a reduced food intake, but it's quality variety. And then very low is, in fact, there is reduced food intake. A couple others that I think are interesting is talking about food deserts. which has been around for a while. And then a fairly new one is talking about the food swamps. And I don't know what you think, but I love being able to have these choices of great words to describe some of the things that we're talking about when we're talking about children and their health and their oral health habits when it comes to diet. Quick look at education. Children not in school, ages 3 and 4, we can see it stayed about the same over the last 10 years. Fourth graders who are not proficient in reading, that's gotten a bit better. Eighth graders not proficient in math, stayed about the same. High school students who are not graduating on time, great increase. Now, you'll note the dates here that it ends in 2019. And I know you have concerns about education for children because of the pandemic. We keep our eye on that kind of information, a very close eye. And it's still just, it's a lot of guessing, a lot of anecdotal information. So, you know, as you can understand, you participated in research projects, you know how long it takes to gather the data and analyze the data and then finally get the data published. So hopefully down the road and not too long, we'll have more information on how children's education has been affected. Information, children who speak a language other than English, children who speak a language other than English and have difficulty speaking English. These numbers have stayed very much the same over the last decade, except for the middle one. That has dropped. So we see the same number of children who speak a language other than English at home, but when they go out into the world, into school, into their dental appointment, far smaller percentage of them have trouble communicating in English. And I love that last number being so high, and it has increased over the last 10 years or so. But it's really nice to see, isn't it, that there's that nice solid percentage of children who are being read to at home.
Robin, in that, sorry,
Yes.
that last slide, is it like a nationwide prevalence? Because in California, we have a much higher percentage of children that speak language other than English at home. It's over 40%.
Oh, yes, absolutely. As we do in Chicago. So these are national numbers. In Chicago, it's about 2 in 5 children. So, you know, in the around 40%,
Yes.
where you are, I don't know precisely what it is, but I would imagine it's a good.
3 or 4 of 5. So it's pretty high too.
Okay, thank you. Thank you. Thanks a lot. Let's take a look at health habits. As you know, after tooth decay, which is the most common chronic disease for children in America, right behind that are issues having to do with obesity. And you can see the percentage of children, and this is, again, middle school, high school kids that we're looking at. About 32% of them are obese. And you can see from these numbers that their perceptions or that the numbers pretty much match. So we're looking at about 30% who are either overweight and obese. Their perceptions is pretty close to on the money. And we see a larger percentage, almost half of them, who say they are trying to lose weight. Now, if you look over on the right-hand side of the screen, you will see some interesting differences based on gender. The blue are boys, the pink are girls, describing themselves as overweight. If we know that the average is about 32%, we might be able to guess that there are boys who may not recognize a weight issue, but we have girls who perceive a weight issue that is not necessarily accurate. And then in terms of trying to lose weight, we see that there is a large percentage of girls who are trying to lose weight, far higher than the percentages who actually are overweight or obese. Next one, average amount of screen time per day. What do you think? Less than an hour, between 3 and 4 hours, between 6 and 7 hours, or 24 hours round the clock? What do you think?
It's a tough one because they keep moving target, but let's how many thumbs up, how many on A, less than an hour? I guess they're not takers. B, between 3 and 4 hours. I guess that's me. Between 3 and 4 hours. How many of you? There's a few thumbs up for B. How about C, between 6 and 7 hours? Wow, there's a lot of thumbs up for C, Robin. And how about D? I hope it's not D. So I guess
okay.
they're between B and C. C's got the highest number of thumbs up, which is scary for me.
And I hope you realize that by now that this quiz is sort of kind of serious, but not exactly, because A, B, and C are all true, because it depends on how old the child is, right? So take a look at some of these numbers. I found them interesting. Under 2, 45 minutes, ages 2 to 4, almost 3 hours. 5 to 8, again, 3 hours. Ages 9 to 12, coming on 5 hours, and then 13 to 18, over 7 hours a day. And that's screen time, like total screen time. All right, let's take a look at health habits in the last 10 years or so. Increase in smoking, alcohol, and drug use. Decrease in smoking, increase in alcohol and drug use. Decrease in smoking and alcohol, increase in drugs, or all three of them, the use has decreased. What do you think?
Oh, it's a tough one. Let's see.
This one, yeah, this one's harder.
How many for A? How many are for A? Read them well. Are there any A takers? One. There's one, Lisa. So B, smoking has decreased, use of alcohol and drugs has increased. So smoking decrease. How many go for B? There's 3 thumbs up for B.
Okay.
How about for C? Smoking and alcohol have decreased and drug use has increased. How many are for C? Any C takers? No C takers. And D, smoking, alcohol, and drug use have all decreased. How many go for D? There's a few, 3 thumbs up for D, Robin. So we're split between A, B, and D.
Guess what? Sometimes the least popular answer ends up being the right one.
Oh,
let's
wow.
take a little closer look.
Wow.
Students who have, let's take a look first at alcohol. 5 or more alcoholic beverages in a row in the past 2 weeks, which admittedly that's a lot of alcohol. Look at those numbers. They have decreased significantly since 2005. And in fact, the numbers are the lowest that they have been like since the 80s. Let's take a look at, okay. When there has been information that is related to the effects of COVID, I have added it. And here's one. Look at, and you're going to note that the numbers don't match what we just saw. And that's because their question about use of alcohol was different. Like, have you had 1 drink in the last week as opposed to 5 or more than twice in the last week? Okay. So, but what we do see is that since the pandemic during 2020 and 2021, there has been a decrease across all age groups in terms of the use of alcohol. Now, what about smoking? Look at that. Have you smoked cigarettes every day and during the past 30 days? lowest, the numbers have dropped. And in fact, again, these numbers are the lowest that they have seen since they started collecting this data back in the 80s. So big thumbs up on that. Now, what this probably is prompting you to think about is the habit of vaping. So here's some information on vaping habits. And you can see that the numbers are pretty high. But you can also see that since the advent of the pandemic, we have seen a drop in the use of vaping nicotine over the last year or so in all age groups. Now, that brings us to the question of use of prescription drugs non-medically. 1 in 100, 1 in 25, 1 in 8, or all of them, of course, except for my kids.
Okay, so how many for A? 1 in 100? Are there any? So there's a couple of thumbs up for A. B, how about B? 1 in 25? There's like 4 or 5 of those. How about C? 1 in 8? There's a couple. Oh, C's, so yes. There's a couple of C's, all of them except my kids. Oh, that's funny. I guess the majority.
That's our answer, right?
That is our answer.
That answer is from both Scott and me. Okay, it is 1 in 8.
Yeah.
It's really high. And you can see that there has been an increase, great information on use of alcohol, great information on use of smoking. We know that vaping has increased in popularity, although we did see a bit of a drop. And then using illicit drugs in the last 30 days, slight increase in 8th graders and corresponding increase in high school seniors.
And Robin, you have no data on now the edibles, right? We're having now data, very, very anecdotal data of 11 and 12-year-olds being exposed to edible cannabis gummies, which I don't think this takes into consideration. That's going to be another huge challenge for us in the future.
Unfortunately, no, I do not. And, I do see some information that has split out use of marijuana versus use of opioids. And there's about twice as many more who are using marijuana than are using opioids. One of the things that we saw is that the students, in fact, this study, the students who reported using illicit drugs, a lot of times it was in combination with, so the use of opioids was in combination with other drugs, including marijuana and alcohol. So that, gets pretty scary. Again, promise to share COVID information with you as it comes out. And if you take a look here, it shows the mental health impact of the pandemic. These are mental health related emergency department visits among children under the age of 18. The blue line, on the side on your left are males, 2019, 2020. You see a definite increase over that time. In terms of girls under the age of 18, you see a corresponding increase, only it's a lot bigger. So we have at least some support for some of your anecdotal experiences or stories that you have heard, that there are kids who are truly struggling in terms of their mood, other mental health issues, definitely on the increase since the pandemic. Did I see that someone's hand is up?
No, I don't see anyone.
Yeah, I had actually put my hand up. I was wondering.
Sorry.
Oh, please, go ahead.
I had put my hand up because I was wondering when you asked the previous question about smoking, were you talking about smoking cigarettes or smoking, like, what exactly did you mean when you said smoking before? Because now we've mentioned like
Nicotine.
cigarettes, smoking.
No,
Okay,
no,
so only, okay, that
no,
makes sense.
nicotine cigarettes that light and have smoke, right? The traditional cigarettes. And then the vaping information that was specifically for vaping. There's information out there on use of chewing tobacco and that sort of thing. I did not choose to include it in this presentation because I want to be done before you start getting bored. Does that make sense?
I was talking about the actual, yes, that makes sense. But I was talking about the poll question, not the graphs, when I just asked that question. So smoking has decreased and you're referring to cigarette usage.
Yes.
Not, okay, thank you.
Sure thing. Let's move on now to kind of a summary. These are messages that I use virtually every day when I'm talking to, when I'm doing outreach to other health associations, creating information for pediatric dentists to use and visit with their state or national legislatures, sending out letters supporting fluoridation or keeping fluoridation, is points to emphasize that oral health truly affects the whole child. So this is not anything, I mean, I'm preaching to the choir, if you will, but if you take a look at these, this list, kids with better oral health can eat and sleep and play and learn better than kids who do not have the benefits of good oral health. We have, some studies suggest that a children's sense of self and the look of their smile can affect children as young as 3. We know that teeth that don't look like other kids' teeth is one of the top reasons for bullying in primary school. And we know that 15 million school days are missed every year due to dental problems, 15 million. So not only poor school performance, but also poor school attendance. Let's move now to information about oral health. Caries prevalence by age. You'll see here, as you know, that the older the child, the more likely they are to have tooth decay. We see about 1 in 5 children will have had tooth decay by the time they enter kindergarten. I will tell you that it looks like these numbers are getting much better, particularly for that youngest age group. In fact, there are 2 competing studies, one on the CDC website and one on the NIH website, in terms of total number of caries in children by various ages. You'll also see that there's a difference between the treated and the untreated cavities. Race or ethnicity, which one has the highest prevalence of tooth decay in 2021? What do you think?
Can you see it nationally or by region? Because I can tell you.
Again, this is national.
So A is white. How many for A? B is Black, African American. How many? There's 1 thumbs up for B. Hispanics. I think I'm Hispanic. C. There's the majority of us who are voting for C. Hispanic. Asians, any for D, Asians. And E, American Indian, Alaska Native. I think the majority of us, we went for C, Robin.
Let's take a look. Right. Here you will see, again, I apologize for the size of this information, but let's take a close look here. For those of you, and we'll see dental caries experience on the left, it's ages 2 to 5. And on the right, it's ages 6 to 11. You will see it according to this particular study only featured 3 race or ethnicity. And you'll also see that it shows the difference based that it is both ethnicity and financial status that will influence tooth decay. And according to the NIDCR report, the one that was originally the Surgeon General's report, but was then published by the NIDCR, American Indian and Alaskan Native children ages 6 to 8, twice as likely to have untreated dental caries in their primary teeth, 5 times more likely to have untreated tooth decay in their permanent teeth than US children as a whole. All right, next one up is, let's take a look at dental visits. These numbers are for the last year. So we'll see that, the numbers are actually like pretty good. Dental examination or cleaning in the last year, we're looking at, a total of almost 84%, which has dropped to around 81. So as you suspected, there has been a drop due to the pandemic. But the good news is that these numbers have significantly increased over the last decade or so. We truly are getting better at reaching children with regular dental care. Here is another one that shows, according to the financial status of the family, less than 200% of the federal poverty level, 200 to 400 of the federal poverty level, and then 400% or more over the poverty level. And you'll see that the numbers, although they have dropped since the pandemic, are still really strong. And the other thing that you will notice is that, yes, there is a difference based on income, but the difference is not as significant as it used to be. One more thing in terms of differences in dental visits, and this is by insurance type. Now you'll notice that the numbers in general seem to have dropped than the 2 previous slides I showed you. That's because, first of all, we're looking at older data. And second of all, this research was done by a different group, which means they're using a different sample and therefore not necessarily going to have the exact same numbers. What we can see, though, is that whether you have private, public insurance or no insurance definitely influences whether or not you are going to get the dental care that you need for your children. You'll also see, though, that the difference has narrowed between private and public insurance. So that is very, very good news. Last topic, and that is parent perspectives. Just a couple of things I thought you might be interested in. The first one is, what percentage of parents say that their primary care provider, which, for example, their pediatrician, told them that their child needed a dental visit? So, we'll see those percentages. We see it's still right around half. And this is after 20 years of reaching out and partnerships and education and joint programming and all of that. It has gotten better. 10, 15 years ago, it was under 50%. And, now, it's over 50%, but obviously we still have a ways to go. Last question. Okay, 2 children. One has their first dental visit at 4 or younger. The other child has their visit over than 4. What's the cost savings to the parents on average? An average cost savings of $360 per child, $695 per child, or there's no actual financial savings because the cost of the visits end up costing just about as much as the treatment did. So the benefit is primarily in the fact that the children have a healthier smile, or of course, priceless.
So how many of you?
Other than priceless, what about the other 3?
How about A? How many of you are going for A? Thumbs up for A. Oh, wow. Thumbs up for B. I think the majority of us were going for B, Robin.
Well, probably in California dollars, the answer would be B, right? But the answer is on average $360. But I'll tell you something, if you're talking to state representatives about the importance of that early visit, $360 a child for thousands or millions of children could really add up, because those cost savings would not only be for the parent, it would also be for whoever's paying for that care, such as a public program.
Absolutely. All our taxpayers' dollars will be saved. Big time.
All right. I'm going to stop sharing, and I'm happy to take any questions or hear any comments. And also, I mean, there was, a certain level of, a certain amount of information here, but you may have some information of your own related to some of these topics that you might like to share with the rest of your colleagues here in the meeting.
Thank you, Robin. I think that you did such an amazing job in summarizing some of the key findings. We just did, by the way, an exercise for all the residents to review the Oral Health in America report, the second supposedly Surgeon General, so they're very familiar with that data. So thank you for the reminder.
Oh, good. Oh, good. Okay. Yeah, there's great data in there. We are super happy that they placed the focus on adolescent oral health as strongly as they did. Really a big thumbs up on that from us.
Also they emphasize on the relevance of the H1 visit, which we're really advocates for that report. We wrote some of those sections in there, really advocating for H1 visit as the way out, the light at the end of the tunnel should be that intervention for all children, and also positioning that as an issue of equity and human rights for all these children should have access to the H1 visit, right? So that's a very important thing. But one of the strong things that I'd like you to maybe give us some feedback on communication skills. We really try to bring the residents with thoughts and experiences on communication, the relevance of communication skills in pediatric dentistry, and how relevant that is. And you with your incredible expertise in communication, can you give us, and I know you might touch this in Washington, D.C., for the folks that they might not be going or attending, can you give us some tips on communication and the principles of what you think are essential for them to learn?
Well, let's see. Have maybe 15 minutes, and that is a week-long question. So let me see if I can't distill it down to just a few points that I think are particularly important. Point number 1, and this is from the bumper sticker on my car. Speak your mind, even if your voice shakes. I know that asking you to advocate for children means that you might have to step out of your comfort zone, talking to people you don't know in venues that are bigger and more serious than you are used to. But I am urging you to go ahead and do it anyway, even if you're nervous, because what do you say to yourself when you see a nervous speaker? Oh, I hate them? Of course not. If anything, you feel some sympathy. So if your voice shakes or your hand shakes, go ahead and speak up anyway. So participate, and I promise you it does get easier. So that's point number one. Point number two, choose your messages ahead of time. And I'm talking about 3 or 4 points, 1 sentence long, and practice them aloud 5 times before the visit. So you don't have to practice everything you're going to say to your audience, whether it's an audience of 1 or an audience of 200, but you do need to, if you say your main points aloud 5 times, which should take you less than 5 minutes, it will be the best 5-minute investment you ever make in any presentation you give for the rest of your life. Let's see. That's 2. 3, you already know, and you're already good at it because you're planning to become pediatric dentists, and that's simplify your language. Not everyone needs the simplified approach, but even those of us who don't need it still really appreciate it. You know, we like it when it's easier to listen. And okay, number 4, third reason I love working with pediatric dentists, you have the best stories. And not only do you have the best stories, but you're really good at telling them. You know, how some people have a lot of stories, then maybe they would have been good, except for the way they tell them, which is like really boring. So you are not in that category. So pick your stories and tell your stories. Other questions?
That's wonderful, Pearls. Wonderful.
You're welcome.
I will just add number 5, be yourself. Be honest and speak with a heart, right?
Well, that would be true for everyone but you. No, I'm kidding. Yes, please be yourself.
Those are wonderful.
Excellent.
Pearls.
Thank you. That is an excellent final point.
Those are wonderful, wonderful.
Bigger and better and outweighs the other 4.
Okay, you guys.
Other questions?
This is your time
Comments?
with our experts. These are our leaders on the AAPD. And you guys are so quiet today. How come?
I just wanted to, I know I haven't been able to participate as much, or I'm headed to a call, but I just wanted to say thank you for highlighting. So I work for Indian Health Services. Just wanted to thank you for highlighting American Indian Alaska Native point. It was something that often gets forgotten.
Yes.
Thank you.
Yes, we have to.
Absolutely.
More advocacy for Native American children are really the hardest hit populations. Very good. Thanks for bringing that. Lisa, you have a
Absolutely. And I can't help but think that because I pulled that information and the sentence that I read to you straight out of the NIDCR report, Wes, that we are going to see continued heightened attention for that particular population. At least I hope so.
Thank you.
Yes. And there's an ongoing, there's ongoing studies that are there yearly for all the different age groups now with Native American, not just children, but adults in all different age levels. And so the pandemic, I think, has probably thrown some of that off, but they've been tracking that data so that we can be more focused in those approaches. And we've seen some positive increases, but it's just not nearly at the same level as all the other groups we've seen. So.
Thank you so much, Wes. Thank you for sharing that with us. Lisa, do you have, Dr. Lisa is one of our brightest and wonderful new faculty members here in the school.
Yeah, so actually, I thank you so much for sharing all of this information. I think, I think over the years, maybe this is a two-parter. I'm just really fascinated with data collection across the nation, and especially something you had mentioned during your talk is that I think we had to switch companies, right, on who collected the metrics. So the metrics changed a little bit. So I guess how do we as an AAPD decide when we want to change what we look at. So historically, obviously, we're going to look at, we're going to stratify caries and untreated decay across, insurance types and age groups. But as we continue to incorporate more social determinants of health, how do we as an organization decide where to focus next in regards to collecting metrics?
Yes, that is a two-part question. And Lisa, I cannot thank you enough for asking it, because I realize that my information and the way I presented it was not as clear as I had certainly meant it to be. This is not information that has been gathered by the AAPD. This is information that is out there that the Research and Policy Center gathers from lots and lots of other sources. When I send you the PDF file of my presentation this evening, in the speaker notes, you will see the source of information. Some of it is government data, some of it is from large universities. So lots of, and that's why sometimes the numbers don't match, is because the National Institute of Health did one with a particular population of children, and then you have another research project from University of Washington in Washington State. You see what I'm saying? So that's question number one. So the information that I presented here is not information that was specifically gathered by the AAPD.
Robin, can I just
So the next, sorry, can I?
go ahead.
Go, yeah, please, Scott, go ahead. Or do you want me to go ahead and finish and then?
You go ahead and finish.
Okay, so I'll keep going and then Scott's gonna clarify everything for me. So second part of the question is how we decide what information we share with our members and what information we choose to gather, which is almost always from our members in a membership survey. Frankly, a lot of it is they rely on me, and I have an advisory board of incredibly smart people, and we take a look at the data and assess it in terms of the quality of the data, size of the population, the responsibility and ethics of the group that's collecting the information. I'm not going to share names of groups that we don't trust, but there are some. And then in terms of how we decide what to ask our members, a lot of times it comes from the members. The members let us know what they want to know about. I mean, right now, we're looking at research on behavior guidance. We suspect that you have changed the techniques that you use, which are more important, which you don't use anymore. And we want to find that out. So that's the next research project that's coming up. I'm sorry, Scott, what were you going to say?
Well, we can forward this afterwards, but one of the challenges Robin raised is the fact that there's so many different data collection sources, even within the federal government. They do have this annual report on key national indicators of well-being that comes out each year, where they cooperate and try to share information among 23 agencies. But again, it's not like there's one survey that everybody's going from. And even in healthcare, to make it overly simplified, depending on how you have to ask the question, like when you're looking at utilization, for example, that can vary by which system you're using. And I know Francisco knows this far more detail than I do, but there's also different outcomes if you have a patient interview or a family interview about their health status or their visits versus looking at insurance claims data. So there's a lot of variables for sure.
Absolutely. We have a few minutes left, and I don't want to leave this opportunity for both of you. You can share with these young, amazing, incredible pediatric dentists and also pediatric dentists to be on the future of our amazing specialty and profession. These wonderful colleagues and amazing pediatric dentists of the future will be practicing for the next 30, 40 years. So you have a message to convey to them what would that be about? They're in the best place, the best specialty. If we have to do it all over again, we will not think twice about becoming pediatric dentists. Just share with them from your perspective the amazing, amazing opportunity that this specialty gives us in life.
Well, obviously, you are my favorite specialty. I certainly had the option of working at other places, and I chose to work for the AAPD. As I mentioned at the very beginning, I think what sets you apart the most is that you do not advocate for yourselves, but rather you advocate for children. I would also urge you to, I don't know, be proud of the choices that you've made and recognize the value in them. And I know that some of you are going to be looking at some substantial educational debt. There are some programs out there that I think can assist you some with that, particularly working with populations that desperately need you. And also that you've met pediatric dentists yourself and you know how much they tell you that it's worth it. The only other thing I would say is please continue to be a member of the AAPD, and please look for ways to volunteer, because so much of what we do is done by people very much like you. And we really appreciate all of the bright minds. And the Research and Policy Center couldn't do much of anything without the support of our volunteers who run so many and do so much of the work. So thank you for that. And thank you for your attention. I've really enjoyed it.
No, we're so appreciative for your talk. And Scott, if you have anything to say, I'm going to ask you permission to maybe bring one or two of my residents to the Governance Council for the Advocacy Day, so they can learn a little bit about the committee work that we do.
Of course, yeah.
Hear that. And also, if you have a perspective, what an amazing opportunity it is for them, especially the ones that are going to be applying for pediatric dentists in the future. If you have any food for thought, it'd be great to have your thoughts.
I think Robin said it very well, that it's a great profession, and there's so many ways you can benefit both in the office and clinic and then in the community. And I think that's the thing that's always impressed me, that pediatric dentists always seem to be very, very active in a whole bunch of things beyond just the clinical practice, which is very certainly time consuming and important and exhausting, but at the same time, I'm just impressed by so many activities you do locally. And of course, a number even do overseas mission trips for their vacation and providing dental care in less developed countries. So I think there's so many great options for people to choose from in this profession. And for those who are coming to DC, of course, in a few weeks, we really look forward to welcoming you, and I think you'll have a great time.
Well, thank you both. You know, UCLA is your home. We hope to have you here anytime you want. In person will be better. But we'll see you guys very soon. Have a lovely weekend and stay warm. And we send you some sunshine from Los Angeles. And thanks again for everything. We love having you be back. Take care. Have a great evening. See you guys.
Thank you.
Thank you.
Thank you.
You.
Much.